Hi, and welcome to this podcast, Better Health for Individuals. In this podcast, we'll be focusing on health as a social construct. In listening to this podcast, you should be able to recognize the interrelationship of determinants, and you should be able to challenge the notion that health is solely an individual's responsibility. We construct our own meanings of health and physical activity depending on our social circumstances. This is referred to as our social construct. It is a concept that recognizes that people have different views based on their social circumstances and ways of seeing, interpreting, interrelating, and interacting with their environment. An example of how behavior happens in a social context is eating. We eat food with our families and friends. Our choices are determined by our social interactions and the organization of the social setting. That is, we will choose different foods if we go out with our friends to a movie, are eating in front of the TV, or if the family sits together at meal times or eats at staggered times. Our choices are affected by cost, advertising, food suppliers, food availability and accessibility, marketing, and agriculture. The personal choices we make in regards to health and physical activity originate in the social, cultural, and economic conditions of our family and community life. Our social construct helps us to determine our beliefs about health, shapes behaviours and lifestyles, provides us with a context from which we can view health and physical activity, influences the extent to which we are healthy or physically active, determines how we use health services, recreational and sporting opportunities, and guides our response to health and physical activity challenges. Factors such as income, education, conditions of employment, power, and social support act to strengthen or undermine the health of individuals and communities. Because of their potent and underlying effects, these health-determining factors are known as the social determinants of health. The World Health Organization has described social determinants as the circumstances in which people grow, live, work, and age, and the systems put in place to deal with illness. The conditions in which people live and die are, in turn, shaped by political, social, and economic forces. According to the World Health Organization, the social conditions in which people are born, live, and work is the single most important determinant of good health or ill health. As factors that affect health, social determinants can be seen as causes of the causes, that is, as the foundational determinants which influence other health determinants. The illustration shows how social determinants extend inward to affect other factors, including health behaviours and biomedical factors that are part of a person's individual lifestyle and genetic makeup. A socio-cultural view of health acknowledges that society, culture, economics, and politics are all significant as environmental influences on an individual. These factors, however, do not make their impact on individuals and communities as isolated factors, but in an interrelated way. Take culture for an example. Ethnicity. People from diverse ethnic backgrounds bring with them different views of health and physical activity. For example, herbal medicine views health in a holistic manner where mind, body, and soul need to be treated together and use such practices as yoga, tai chi, meditation, and massage. Physical activity and sports participation is also reflected in our ethnicity. For example, it may provide for the creation of social networks, for example, cultural-specific dance groups and sporting clubs, and the maintenance of cultural identity through participation in traditional sports, for example, bocce. Ethnicity may also hinder participation. For example, Muslim women are prohibited from swimming in the presence of men. Race or cultural heritage also have an impact. For example, Aboriginal people view health in an holistic manner and will consult elders in treating illnesses in a way that considers the spiritual, physical, social, and cultural aspects of health. The dominant culture also has an impact. In Australia, it is a middle-class Anglo-Saxon urban culture. It has definite views about health and physical activity. It emphasises that medicine is based on scientific evidence, modern healthcare, and mainstream medicine. Complementary medicine, for example acupuncture, is gaining more acceptance, however. The construction of gender, that is, the ways of being male and female, affect health and physical activity also. Homophobic behaviour is a result of ways of thinking about what constitutes manliness and the ways that males should behave. There is less promotion of women's sport and participation in physical activity. Stereotypical views of females restrict participation in activity. And westernisation. Western culture constructs health and physical activity in different ways to other cultures. Obesity, anorexia nervosa, and bulimia nervosa are said to be specific to Western culture due to media-imposed body images, technology, fast-paced lifestyle, and convenience foods. One particular well-documented aspect of the relationship is the special role played by income and other related indicators of material affluence and socio-economic position, such as education and occupation. That is the focus of this snapshot in the context of Indigenous health outcomes. Socioeconomic status relates to levels of income, education, employment, and car and home ownership. Meanings given to health and physical activity vary between people of high and low socioeconomic status. This can be due to living conditions. Poorer, less educated people are more often exposed to unhealthy home and work environments. Access to and information about choice of healthcare services. The likelihood of using preventative health measures such as pap smears, immunisation, and breast screening. The value placed on personal health and behaviours that contribute to healthy lifestyles. The social determinants of health related to socio-economic position help to explain both the gaps in the average health status of Indigenous and non-Indigenous Australians, and also the wide variation observed in the health outcomes within the Indigenous population. People with higher incomes live longer and have better health on average than do people with lower incomes. This strong link occurs not just with high levels of income, but with a wide range of characteristics that denote a person's socio-economic position, including educational attainment, employment, and occupation. The higher the socio-economic position, the better the health status on average. One example of this relationship is the difference in behavioural risk factors associated with employment status. Indigenous Australians who are unemployed face a higher risk of poor health through higher rates of smoking, substance use, and dietary behaviour, such as a lower level of daily fruit consumption, compared with Indigenous Australians who are employed. A counterexample of a risk factor that has a higher prevalence among employed Indigenous adults is being overweight or obese. Another example is geographic location. These are urban, rural, and remote. People who live in these areas are likely to have varying constructs of health and physical activity because of their circumstances. People in remote areas are less likely to consult medical practitioners because access to them is limited, and they are more likely to be exposed or less likely to be exposed to health promoting messages. The opportunity for organised physical activity is also much less. Physical environments can be changed, rearranged, maintained, or destroyed largely through political power, community pressure, and environmental laws. The environment can sustain or raise health status through the provision of clean water, uncrowded housing, and effective sewage treatment. These are referred to as public health initiatives. It can be limited by economic considerations, social power, politics, and the culture of protection. An individual view of health used alone has limitations in addressing health concerns because our individual meanings of health and physical activity vary from one person to another due to our different social circumstances. This is based on our different ways of seeing, interpreting, interrelating, and interacting with our environment. Individual behaviour will vary according to our social construct we are in. Our language and behaviour will be different when we are around our families, at school, with our peers, and in various social settings. For example, on a date or at the movie with our friends. Behaviours such as drinking will change according to the situation we find ourselves in. For example, drinking around family as opposed to being out with our friends. Health is a fundamental right for all Australians. Therefore, it is collectively an individual and community responsibility. When compared with an individual view, a socio-cultural health perspective identifies the behaviours that lead to health problems and the specific populations at risk, gives us some underlying reasons for these behaviours and trends, acknowledges that our immediate social, cultural, and economic environments interact with our emotional resources and coping skills to help determine our health status, shows how the broad social and cultural forces can shape or limit an individual's decision-making, affect power relations, and determine the amount of control an individual has over his or her behaviour. In summary then, the idea of viewing perceptions of health as something that is socially constructed means that we can recognise that its meaning will vary over time, from individual to individual, from context to context, and from culture to culture. It is with this understanding that the health as a social construct idea helps us to understand why certain groups behave in particular ways, why some people or groups do not have the same chance to achieve a high level of health as others, how culture and an individual's social environment can influence a person's behaviour, and that some upstream factors are unmodifiable by the individual. It also helps us to understand that good health is subjective, it is a construct, and a result of a complex interplay between the determinants, that is, the individual factors, socio-cultural, socio-economic and environmental factors, some of which individuals have no control over, such as pollution, access to preventative and primary healthcare facilities, and costs. Good health can only be achieved by balancing individual responsibility and choice with responsibility for service provision by governments and non-government organisations. When responsibility is shared, there is a greater chance of an individual achieving good health. For example, smoking rates decrease because of individual responsibility and choice to quit. Support from government, such as Quit for Life, and legislation such as plain packaging, limiting places where people can smoke, and non-government campaigns to encourage and support people's decisions to quit. Thank you for viewing this podcast. In completing your work, make sure that you have gone through your notes to recognise the interrelationship of the determinants and be able to respond to the challenge and the notion that health is solely an individual's responsibility. Thank you for listening.